Hello and welcome to our webinar. I'm conscious there'll be people continuing to join over the next couple of minutes, so hopefully that won't be too disruptive for everybody already here. My name's Ben Troke. I'm a partner in the health advisory team at Hill Dickinson Solicitors. I'm based in the Leeds office, but I work nationwide. I have a part in coordinating our support on the liberty protection safeguards for our clients across the country, NHS providers and commissioners, the independent sector, local authorities, and so on. And I'm really glad to see all of those different parts of our client base and contacts well represented in such a large audience. I'm really glad that so many of you can join us today. The title of our presentation is Liberty Protection Safeguards Update and Next Steps. This is partly to assure people with an eye on the April 2022 deadline that you are not missing anything, you haven't missed anything. If you think we're all still waiting for the code of practice, then you're absolutely right. We are, but I will share what I can by way of news and gossip about the timescale of that. But I also wanted to put the emphasis on next steps. It's increasingly obvious that we can't just wait for the code of practice to come out for consultation before we start our thinking, before we start our preparation on getting ready for the liberty protection safeguards. And there is plenty that can and I think must be done now to make a start, both in terms of legal issues, which will be covered by my colleague Paul Alliston, who will speak about that, and governance, on which you'll hear from Elaine Dower from 360 Assurance, and we're delighted to be doing this session jointly with them. Given the numbers of people attending, you'll appreciate it's a challenge to make it as interactive as we would like to. And I'll cover the housekeeping in a second, but one way we'll do this is by using Slido. I would guess lots of people are familiar with that at this stage in things. But if not, you simply go to that website or you scan that code on a phone, and that will then give you access to poll questions. We'll be using that to ask a couple of questions before we get started, and we'll come back to some more questions throughout the session. So please do leave that window open once it is open. Just while I leave that slide up, so you can be doing that, let me cover a bit of housekeeping. I hope that you can all see and hear me okay. I'm going to set the scene in just a couple of minutes and then hand over to two other speakers. Because of the number of people attending, we have muted all of the microphones, and we would ask please that you do turn your cameras off during the webinar, just to help with the bandwidth. We won't be offering unmuting microphones and asking questions verbally. Given the numbers of people, we will ask that you use the chat function, please, to put questions in writing. Please do keep them short and sweet if you can. I know there'll be plenty to talk about. But if you put questions into the chat box, I will be keeping an eye on those during the presentations of my colleagues, and we'll come back to them with plenty of time at the end. We are recording the session, so the recording can be made available afterwards, and the slides will be sent out afterwards. I'm conscious there's quite a lot of content on some of the slides. That's deliberate, and you will be getting them afterwards, so you don't need to scribble down every word on every slide as we go through. Before we get to the agenda that we'll cover, actually forgive me, I've read out effectively the housekeeping already. So let me tell you what we're going to say. First few minutes, introduction and welcome. That's what we're doing just now. There'll be 15 minutes or so of legal issues, which my colleague Paul Alliston will present on, and then organisational preparedness, which will be Elaine Dower from 360. Hopefully lots of time for the Q&A when we pick them out of the chat box to finish the session, and then we'll close at 12. As I say, we'll have a couple of Slido questions at the beginning and some more at the end, just to come back to. So if we could put up the first Slido question. This is just to gauge the audience, because it's very different doing this sort of presentation to people online than having 300 people in a room. You can sense the mood and the temperature a little better. So to set the scene, this is free text. Put in a word or two for how you're feeling about the LPS right now. Just to give us a sense of where you're starting from. And I'll give you a few seconds just to do that, please. And that should come up in real time on the screen in what I'm told is a word cloud. Interesting. Okay, there's answers still going into that, and I'm struggling to see it past the box which pops up every time someone wants to join. But what are the headlines from that? Unsure, unclear, apprehensive, unprepared is interesting. Oblivious, that's nice. There was someone who said oblivious. We've done well to turn up today. There's a bit of excitement, underfunded, panicked, not prepared. Okay, pending the code, that's interesting. We'll come back to that. Concerned, uncertain, good knowledge. So there are some positives in there, good knowledge and excited. Let's move on to the next question, anticipating that there might be some hesitation, some wariness in the mood at the moment. Can you help us, please, again, just in a word or two, if you can, pick out what is it that's on your mind? Which aspect of the LPS are you most worried about at the moment? Okay, training and limited knowledge are coming to dominate. Resources, I was expecting to see resources come through. Lack of clarity, who does what the role of the BIA will become, that's interesting. Doctor's diagnosis. Okay, so comments going into the comments box as well. If you put it through Slido, if you can access it, it'll go into the word cloud, and this will also be something that we circulate after the session. Okay, interesting. So limited knowledge, who does what, training, resources, and lack of code. Lack of code, right. Let's talk about some of that. Elaine, if you wouldn't mind moving on. Thank you. Right, I've got two slides really to set the scene, then I'll hand over to Paul. I've used the Waiting for Godot as a slightly more highbrow reference, but here I had in mind, I suppose, the rhetorical question. Have you ever had a sense of waiting for something and waiting for something that feels like it's never actually going to really happen? In my world, that's about the gap between the excited gossip and speculation about the football transfers and my club's abject lack of actual activity. But Waiting for Godot, perhaps a bit more highbrow reference. Here, really, what we're waiting for is a simple answer to what ought to be a simple question, which is this: how do we protect the rights of people who can't make a decision for themselves about their own care and their own residence? They lack mental capacity, but arrangements are made for them in their best interests, however well intentioned, that amount to a deprivation of liberty. How do we meet their Article 5 rights? It shouldn't be a complicated question, and it shouldn't be a complicated answer. Essentially, how do we plug the Bournemouth gap identified in the Bournemouth case 17 years ago. Now, the Mental Capacity Act was amended to introduce the deprivation of liberty safeguards by legislation in 2007, in force in 2009, so 12 years ago. But DOLS was at best a partial answer. It only applies in care homes and hospitals, and it's not a simple answer. Even the biggest fans of DOLS can't say it's a simple answer to that simple question. It is complex. 10 years ago, we had the judgment in the case of Neary, the 20-year-old young adult with autism and a learning disability who was placed in respite care for a few days by the London Borough of Hillingdon and stayed there for a year against his wishes, against his father's wishes. Now, you might see that as a success story for DOLS because it's a Section 21A application that secured his return home to his dad. The Court of Protection worked in that case, but it's hard to see it as an example of DOLS being used well or doing their job properly by the local authority in the first instance. It's 7 years since the Cheshire West Supreme Court judgment, which I know you'll all be familiar with, taking a broader view of the definition of deprivation of liberty, and if the system wasn't already unfit for purpose, as the Post-Legislative Scrutiny Committee of Parliament had already said it was, this judgment increased the workload to stretch it beyond breaking point, and we now had backlogs of a year or more. Question: what's the point of a system of safeguards where you trigger them and someone has to wait a year for someone to turn up and do something about it? Equally a question: what happens to the DOL in the community cases for whom only an application can be made to court, and the less visible backlog there? It's 4 years waiting and waiting. It's 4 years since the Law Commission recommended a wholesale set of reforms to the law of deprivation of liberty, and it's 2 years since rather different recommendations than the Law Commission's, but still using the title Liberty Protection Safeguards, were passed by Parliament in 2019, more than 2 years ago. And yet we're still waiting and waiting. At the moment, we're waiting for the draft code of practice and the draft regulations to come out for consultation. These were expected in spring 2021. Then I last heard the end of June. What I now hear is the real deadline is the 23rd of July, because that's when Parliament goes into recess for the summer. The code of practice to go out for consultation must be laid before Parliament. So if we don't see it by the 23rd of July, and we expect to, but if we don't, then it will be into September. That's a 3-month consultation period, plus whatever time it then takes to think about the consultation responses and make any changes. So we're still many months away from seeing a final version of the code of practice. And of course, the first date for the implementation of the liberty protection safeguards has been and gone already. It was to be October 2020. It's now said to be April 2022. But you will see, even if we do see the code out for consultation in the next few days, plus 3 months for the consultation, plus time for response to it, plus time for planning workforce, perhaps one of the biggest issues and less often discussed. April 2022 is likely to be unrealistic already, and I would fully expect an announcement imminently that will be pushed back to October 2022 at least, and it might well go back further if we don't get the code out before the summer recess. Next slide, please. Thanks, Elaine. So whenever I've been asked to give training on the liberty protection safeguards over the last couple of years, I've always used this sort of image of a sort of crystal ball, because there's always lots of really good questions to which the answer is we don't know yet. We're waiting for the code of practice. The only thing that's certain is that there has been delay and there has been uncertainty, and there's more layers of uncertainty. We've had a new Secretary of State in place for 8 working days, and with 1 or 2 other things on his mind just at the moment. Just yesterday, we had the Health and Care Bill introduced, which abolishes CCGs next April before they even get their hands on new responsibilities that LPS was supposed to give them. And every time I see an alert that guidance I'll do this. Guidance has been published by the Department of Health and Social Care. When I read it, it seems to be a promise of guidance that will be published at some point in the future. So it is tempting to say, well, we'll just wait for the code of practice, and then things will become a bit clearer. But I don't think that's good enough. I don't think the code of practice will bring all the answers. It's a significant document because lots of the controversies in the legislation were kicked down the road to the code of practice. We'll deal with it in the code of practice, was the way a lot of difficult questions were dealt with in Parliament. But it won't have all the answers. When we do get it, if it is in a couple of weeks, it will be out for consultation, and it won't be in a final version for many more months to come. And by the time we do get it, it's likely to be too late to really make a start on planning for implementation. And arguably the workforce plan is more important than the code of practice anyway. So what I think we can and we must do now is take stock, realise that we don't know all the answers about the liberty protection safeguards, but we do know enough about what they'll look like in some really important ways. We know enough about things that won't change in the new system in really important ways, and we know enough about things we can and we must be making a start doing now. And that comes under two headings, both legal issues and governance issues. Elaine Dower is going to talk from the governance perspective, but first I'm going to hand over to my colleague Paul Alliston to cover some of the legal issues. Over to you, Paul.
Thanks, Ben. So I'm Paul Alliston. I'm a partner in our Manchester Health Advisory team, and yeah, I'm here to run through some of the legal issues. So there's going to be some really big changes in the LPS. The LPS system entirely replaces the DOLS, whether that is from April or October 2022. DOLS is being swept away and it's being replaced entirely with the liberty protection safeguards. It's going to try to confront some of the inadequacies in the DOLS. So one way it does that is that it now applies not only just to hospitals and care homes, but to all settings where the person is deprived of their liberty. So it doesn't confine a DOL to an institution. It's not the institution that detains someone, it's the arrangements that do this. So by extension, there will be portability in that it will now also apply to multiple settings. So not just authorization of restrictions in just one place. Another inadequacy of the DOLS was the over 18 requirement, and the LPS will apply from the age of 16. And as the LPS comes within an amendment to the Mental Capacity Act, it does look at Section 4B of the Mental Capacity Act, and it expands on the current provision for an authorization to deprive someone of their liberty to carry out a life-saving or vital act. So it replaces the current urgent authorizations and provides for three things that you might call an interim deprivation of liberty. So first, where you're waiting for the Court of Protection to decide whether the DOL is lawful. Second, where you're waiting for the responsible body to complete the authorization process. And lastly, when you're in that emergency and life-saving scenario. Assessments are supposed to be streamlined and built into care planning. So not an after the event, marking your own homework after the situation is settled. The LPS is about putting considerations about deprivation of liberty to the earliest possible stage. So it wants to avoid those situations of the past where people are moved and retrospectively recognizing that they're going to be deprived of their liberty and then having to do something about it, by which time it's too late. And then three things that are really important. So there are going to be longer authorizations. So instead of the 12 months maximum, there can be 12 months, then a 12-month renewal, and then 36 months on the second renewal. The independent scrutiny is more focused or rationed. So instead of the BIA reviewing every single case, you're going to get an AMCP who only reviews cases where the patient or individual objects. So if it's reasonable to believe that the person doesn't want to be there, then there'll be higher scrutiny. It remains to be seen how that's going to survive any challenge to compatibility with Article 5 once it's in place, but we shall see. And then big change, the burden of authorisation is going to be spread. So it's a big shift from the DOLS that was focused on the local authority being the centre of thinking around deprivation of liberty and everybody else feeding in. LPS is thinking, well, what's really important is that the people responsible for bringing about the deprivation of liberty should also be responsible for coordinating the process, that it's not arbitrary. So avoiding the situation with the DOLS that would be challenged against the local authority, which may have nothing to do with putting the arrangements in place. For example, when the arrangements are being funded by a CCG. So spreading the burden where NHS trusts will pick up when it's a patient of theirs, and if it's a CHC commissioned care package, then the CCG will pick that up as the responsible body. So those 3 points are doing things more cost efficiently or saving resources, particularly the resources of the local authority, by sharing some of the cost with the NHS. So there's some really, really big changes. But Elaine, could you flick the slide, please? Thank you. As you can see, some things are going to stay the same. Plenty of things are going to stay the same, in fact. And that's where we can focus our efforts and preparation at present. So we won't see a statutory definition about what it means to be deprived of your liberty. There'll be guidance in the Code of Practice, which is going to stay in track with the case law on this. So we're still on the acid test until any development on that. The numbers won't reduce. We're talking about the same cohort of people. And if you factor in all the people who are not in care homes and hospitals and 16 and 17-year-olds to boot, then we could be talking about a significant addition to the current numbers. It may even double the number of people who are going to be in the LPS system as opposed to the DOLS. But every person in the LPS system keeps that right to non-mean tested legal aid for appeal of the authorisation in the Court of Protection. So the mechanism for that is going to be Section 21ZA. And a question comes about is, well, is the COP caseload going to double as a consequence? And how is that going to cope? Again, we shall see. The interface with the Mental Health Act is going to be rolled forward broadly in the same format. I think the plan is to see how the LPS beds down and then review. But maybe separately, there's going to be a big difference made by the reforms to the Mental Health Act being proposed, which are going to exclude autism, spectrum disorder and learning disability patients from the criteria for detention. The consequences for an unlawful DOL won't change, so all the issues are still going to be there that we already know about. And then finally, the two systems, DOLS and LPS, are going to run in parallel, where a DOLS authorization has already been given. So lots of things we know will stay the same, but there are lots of questions that we don't know the answer to. So one question is, well, how is the Code of Practice going to give us examples about applying Cheshire West in practice? In terms of life-saving medical treatment, I don't see how you can describe this as not a DOL because of Ferreira, as opposed to a DOL that is authorised under Section 4B. So don't know how those lines are going to be drawn, and there's some uncertainty there. I appreciate you may all have questions about that, and we are with good company in that Ben acted for the Intensive Care Society in Ferreira, and he's got the same questions as me, so maybe we can come back to that in the Q&A. There are 3 assessments that need to be carried out under LPS, so who's going to be carrying them out? We're waiting for the code, we're waiting for the regs. Who's going to be doing the pre-authorization reviews? Who's going to sign off the authorizations? What level of training do you need for each of those roles? What level of resources are going to be required? How many AMCPs are going to be needed? That's going to correlate to how many people there will be a reasonable belief that they're objecting to the arrangements. How do we define objection? It's going to be incredibly tricky, but yet hugely important in the LPS system. The LPS, as enacted, had a special role for care home managers. That's dropped because of the conflict of interest concerns. But will it come back? We don't know. And then what about the backlog of cases that have been referred to DOLS but haven't yet been processed at the time of implementation? Again, we just don't know what's going to happen. So there's a lot of stuff we don't know, and we are, as I say, waiting for the code. We're waiting for the regulations. But Elaine, could you? Thank you. What we do know already is that the most important thing about deprivation and liberty and about LPS is that it's not about DOL. It's not about deprivation of liberty. Each of these cases on the slide, they're really high-profile cases, ended up with substantial awards of compensation when people's rights have been breached. These cases and others like them that don't generate compensation should be measured not just by their compensation awards, but by the adverse impact on the lives of the vulnerable individuals they concern. And they're sobering from public body perspectives. So in Neary, as Ben mentioned earlier, London Borough of Hillingdon ended up paying £35,000 in compensation to Mr. Neary and to his father for breaches of their rights when Mr. Neary went into respite for a few days and was kept there for a year. In Essex Bona, a discharge decision in hospital so badly managed that her estate was awarded about £15,000 in compensation for false imprisonment for the 119 days after she said she'd wanted to go home. They didn't assess her capacity to make that decision properly, and they excluded the family from the best interest decision making, such that a further aggravated damages award of £5,000 was made for failures to adhere to the Mental Capacity Act. And then in Emil, the local authority in that case sought to recover £80,000 of unpaid care home fees from a lady's estate after she died, and instead ended up paying £130,000 in damages for the unlawful deprivation of liberty. There was no DOLS authorisation for 8.5 years of her time there. And worse, the LA hadn't even considered properly whether it was in her best interest to be there or remain there at all. So I think the lesson of each of these slides, and building off the initial point, is that the problems come from getting the MCA badly wrong to start with, not the DOLS due process. And Elaine, if you can flip the slide, please. Getting the MCA right is a good juncture to briefly touch upon the pitfalls, the most common pitfalls. So being unclear as to what decision needs to be made, the conflation of capacity and best interests, the protection imperative, as the courts have referred to it, the temptation of risk aversion, particularly for public bodies, either for assessing capacity to make a particular decision or in taking the safest option, even when that's not necessarily in the person's best interest. Misunderstanding our role as public bodies, seeing ourselves as the servant, not the servant, but the master in cases where we're making decisions for incapacitated people. And getting it badly wrong in consultation with P and others, including their family, when making best interest decisions, and overlooking Article 8, something often goes badly wrong. Next slide, please. So I suppose the top line for preparing for the LPS, whatever they're going to look like, and something we can be getting on with now, is focusing on embedding good Mental Capacity Act practice, MCA practice, and we're going to come on to that later. But there is something that you can be doing in relation to DOLS and LPS specifically, and I'm just going to touch upon that over the next few slides. So if we can go to the next one. So as an NHS trust, you can and you should be scoping out how many cases you currently refer for a DOLS authorisation How many more would there be if you start counting in 16 and 17-year-olds? How's that going to be affected by the proposed reforms to the Mental Health Act, excluding LD and autism patients? Next slide. As a CCG, it's all about continuing healthcare function. So that's how the responsibility to CCGs comes into play. And the questions up on the slide might not necessarily be ones that can be answered easily. So how many CCG cases do you have? Certainly the next few questions are certainly ones that many CCGs can't answer at the moment, and indeed for quite some time, because I've been asking those questions. How many of those individuals lack capacity to make decisions about their care and residence? How many have restrictions in their care package that might amount to a deprivation of liberty, as per the ASTA test? For those cases, don't wait until the LPS comes in, or is in fact bedded in. Get them to court now, because for those cases, you're not going to have to treat the implementation of the LPS as a hard cutoff. Next slide, please, Lynn. For both trusts and CCGs, you need to be thinking about how many people are objecting to their care package or restrictive measures. From that, we can attempt to work out what sort of AMCP resource we're going to need. Have a think about who might be doing the LPS assessments, who might be doing the pre-authorization reviews, authorizations. Look at the workforce plan when it comes out. And remember that the IT systems are going to have to be looked at, as there's going to be a lot more data being reported through LPS than there has been for DOLS. Next slide, please. Make the most of the equivalent assessment. So using the stuff that we've already got available through the care planning and everyday provision of records. Think about ways as to how it's going to make it easy to pull that useful information out. For example, where you've got diagnosis in medical records. There's going to be a big issue in terms of comms and PR. So understanding that this is going to be a big change in the roles for different organisations, and thinking about that communication piece is something that you can give thought to now. And then, just in case something does go wrong, start being mindful of the potential liabilities. Discuss those liabilities with your insurers or NHS resolution. Next slide, please. Just briefly touching on the independent sector. How many patients do you have in your care that are likely to lack capacity to make decisions about their care and placement? How many of those are in circumstances that amount to a DOL? And then what resources are you going to need in place for that LPS process? So a few things to touch on for the independent sector. Last slide, I think, for me. Everybody, I suppose, make a start. Make a start now. Don't wait until LPS comes in. You know, don't wait until it starts bedding in. Don't wait till it's too late, because it will be too late. You need to be building LPS thinking into your care provision right now, because I say it's going to be too late if you leave it until everything's finalised. You can be thinking about the different staff that are going to be involved in it. You can be thinking about the level that they're going to be, level of staff members being involved in it. You can think about how much they're going to need to know and what training and support they might need. And the last point on the slide, to repeat a point I made earlier, get the MCA right. Because if that foundation is in place, then DOLS and LPS won't cause you the types of difficulties and uncertainty and anxiety that we saw on the word cloud earlier. So invest in MCA training, invest in refreshers, in audits and support. And we're going to come back at the end to tell you how we can help you with that.
Paul, thank you. Thank you very much. I will pass swiftly on to Elaine because we are predictably wildly overrunning already in how long we said we'd take for our bit. So with apologies to Elaine, over to you, and hopefully there'll still be some time for Q&A. I'm trying to answer questions as they come into the chat as we go, but do keep sending questions in, and we'll make sure that there is some time for discussion of those before we finish at midday. But Elaine, over to you. Thank you very much.
Thank you, Ben. My name's Elaine Dower, as Ben said, and I work for 360 Assurance. So I appreciate that some of you might not have heard of 360 Assurance before. So we're an NHS-hosted internal audit and independent assurance provider, delivering a service to 27 NHS organisations, primarily in the East Midlands and South Yorkshire. We're also a member of the Internal Audit Network, TIAN, which is a collaboration between all the NHS-hosted internal audit consortia and in-house teams in England, together covering approximately 50% of NHS organisations in the country. 360 Assurance are the only internal audit consortia to have a substantive team of clinicians, of which I'm proud to be a member. My background is as a general nurse, but I undertook a master's in mental health law and got hooked. I subsequently went on to qualify in the first cohort of BIAs back in early 2009. So now, working in internal audit, I can provide clients with independent assurance around the systems and processes they have in place to ensure compliance with the principles of consent, the Mental Capacity Act, and the Deprivation of Liberty safeguards. And it won't come as any surprise to any of you when I say that what we find through our independent assurance work reflects the national reports. Practice and understanding are variable. We find pockets of excellent practice within an organisation, but it's rarely consistent across the organisation or between organisations. I'd reiterate what Paul has already said about using this time to really consolidate staff knowledge and understanding about the MCA and the variety of situations which might constitute a deprivation of liberty. In doing this, you may need to really take a critical look, an objective look at how you're training your staff and the time, energy and resource you're willing to commit to this fundamental area of practice. I've seen some excellent e-learning, and I've seen really passionate and committed trainers delivering face-to-face sessions, but they're often trying to cover consent, the Mental Capacity Act and DOLS in half a day. So even in organisations where the compliance with this type of training is 90% or more, when we go on to the clinical areas, the evidence that the MCA is being applied consistently in day-to-day practice is still consistently lacking. The translation of theory to practice is not consistently occurring. Organisations really need to think about the way they're delivering training if they're serious about embedding the MCA. If you've got concerns now, doing more of the same training probably won't work. Which brings to mind this quote about the definition of madness or insanity, which is often attributed to Einstein. So doing the same thing over and over again and expecting different results. So in terms of the context or the scale of the challenge, there's no doubt that there's a big undertaking ahead. So the impact assessment, which was revised by the government in January, makes a number of assumptions. And there are some figures in the impact assessment which many of you might easily challenge, and we'll touch on a couple of those in a minute. But where those assumptions could be challenged, it might mean that the level of any central funding does not match the plans currently being modelled by organisations. So the first point is that the impact assessment is based on the 1819 DOLS application numbers, but the 1920 numbers for England show approximately a 10% increase, and there's a similar scale of increase for Wales. Continuing healthcare figures show that on the 31st of March this year, 51,714 individuals were in receipt of fully funded NHS continuing healthcare. It's impossible to accurately assess the proportion of these that may be deprived of their liberty outside of a hospital or care home setting. But when you consider adding in the numbers of joint funded care packages, local authority funded social care packages and self-funders, it seems almost obvious that there'll be many more deprivations of liberty occurring outside hospitals and care homes than the 2,897 applications which were made to the Court of Protection in 2020. The impact assessment estimates an additional 59,600 applications across England and Wales from community settings and in respect of 16 and 17-year-olds. But even this might seem like an underestimate. Let's not forget that the 2007 DOLS impact assessment estimated a worst case scenario of 21,000 DOLS applications a year. So given that staff at 360 Assurance are NHS employees and we're working on behalf of the NHS, we're undertaking a project this year supporting NHS organisations in our geography and their integrated care system partners with their preparedness for implementation of the LPS. So this works twofold. The first part is through individual discussions with each participating organisation, gaining an understanding of where different organisations are at, including what their previous numbers of DOLs, REEx applications have been, whether it's genuinely felt those are accurate, what their estimates are for LPS, current numbers of BIAs, where the administrative process will sit, etc. And we're then going to undertake benchmarking of this information. And I've put benchmarking in inverted commas as people interpret the phrase quite differently, but I'm referring to drawing out the main commonalities, identifying the outliers and highlighting and scrutinising the areas of greatest variation. The idea is we'll share that information back out with participants to enable their internal and system-wide discussions to encompass the full breadth and diversity of current ideas, suggestions and models in circulation. This will be in an anonymised way, except where explicit consent has been gained to attribute a specific example or idea. So from the conversations we've had so far, we're already seeing some huge variation emerge. And some of these points go back to those questions that Paul was talking about. So whilst the rapidly forming integrated care systems have a lot to think about at the minute, especially with the bill published yesterday, it seems that in some areas, individuals are struggling to get LPS high on the ICS agenda. So whilst the operational leads in a number of ICS regions have organised themselves to meet as an ICS-wide LPS group, it may be a challenge to outline and get approval for certain aspects of the LPS arrangements, which could be managed at an ICS level. So it seems like there may be clear efficiencies, both in terms of effectiveness and financial efficiencies, to having AMCPs, say, or IMCAs pooled at an ICS level. In terms of Ferreira, we know of acute trusts that hold the position that nearly all patients receiving treatment in an acute hospital require this treatment in order to prevent a serious deterioration, and therefore DOLs are not generally utilised. Others have applied the Ferreira judgment only very narrowly to their ICU and still apply DOLs throughout the rest of the hospital. So some consistency and further guidance will obviously be welcome, but will also significantly affect the numbers of estimated LPS applications. In relation to REEx, the breakdown of court of protection applications by region is quite remarkable, with some significant number of areas not submitting any, and others submitting in the hundreds. This indicates very different thresholds and or very different acceptance levels of the risk this poses in terms of potential legal challenge. These things clearly affect how organisations and ICS partnerships will estimate their overall numbers and staffing requirements as a result. The impact assessment works on the basis of 26% of referrals requiring AMCP involvement. But the majority of the organisations we've spoken to so far are reckoning on a much higher proportion, taking a low bar for objection. The impact assessment suggests that there are currently 2,720 BIAs in the country, but only 1,073 AMCPs will be required under the new LPS system. So if all BIAs converted, then theoretically, there'd be a considerable number of them sat around without a role in the LPS process. But I'm not seeing a huge clamour amongst local authorities to 2p over their BIAs to NHS organisations. It doesn't feel at the minute like they see the workload dropping off enough to be able to reduce their staff numbers. So in most organisations, responsibility for MCA and DOLs sits within safeguarding teams, or where they exist, specific mental health legislation teams, which might also include MHA admin. There have been a number of comparisons made between the LPS process and the Mental Health Act process within hospitals. And there are some parallels which can be used to good effect in terms of learning, but there are also some significant differences which we need to be aware of when considering the new processes. It seems most common amongst the NHS organisations we've spoken to be considering the pre-authorisation review at a band 6 level, but the spectrum of possible authorisers is quite extreme so far, ranging from band 7 to band 8C. This is mirrored somewhat already in the local authorities, where the range seems to be group manager to service manager through heads of service to assistant directors. Again, consistency I think would benefit all. The assessments required, mental capacity, mental disorder and necessary and proportionate. The government's expecting that the majority of cases, the documentation that's already in place at the point of referral into the LPS system will provide the necessary evidence for the pre-authorisation reviewer. Here they're thinking about the admission documents and clerking and risk assessments and care plans. I can't speak as much for social care, but I would suggest that within the NHS there may be some work to do to enable existing documentation to be relied upon. And particularly at the start, a significant number of specifically requested assessments I think will need to be completed. In the majority of NHS organisations, DOLS info is currently collated on an Excel spreadsheet. Ideally, where organisations have electronic patient records, these should be adapted to enable reporting of the information you need, rather than setting up separate systems. But how feasible is that actually going to be? You'll all have subject matter experts within your organisations to help with identifying and recommending the appropriate policy, process, checklist, data capture, etc. But being an internal auditor as well as a clinician, I'm going to ask, what about the governance, the risk management and assurance? From work we currently do, we know the internal assurance around DOLS within organisations could be significantly improved. Numbers of applications are consistently reported, but that's often not accompanied with assurance regarding the completeness of that documentation, whether the documentation demonstrates good understanding, what the estimated levels of underreporting or non-identification are. Therefore, the resulting risks can't be easily and explicitly identified. And if risk isn't identified, it obviously can't be properly managed and mitigated. So if you could now return to your Slido window or pick up your other device with your Slido open, I'd just like to run us through a few quick questions aimed at responsible bodies. So the first one, has your organisation identified likely numbers of LPS applications? Answers yes, no, or in progress. So I think we were getting about 70 people answering previously, so I'll wait till the numbers get near that. Okay, far fewer confident that they've got some likely estimates there, and that's what I was expecting in terms of conversations we've had. So moving on to the next question then, because I'm conscious of the time. Is there any, if so, have you identified how many of these are likely to need a pre-authorization review conducted by an AMCP? Yes, no, in progress, or not applicable? Okay. Numbers have slowed down now in terms of coming in, so I'll move on to the next question. Is there any consideration being given to an LPS hub model within your county or ICS, where AMCPs and or IMCAs might sit at a system level for utilisation by the various responsible bodies working within the system? So not sure is coming out on top here, and I guess that might be in terms of the first point I was making about that ICS buy-in and getting those conversations happening. Okay, and then the final question for this section, for new responsible bodies, i.e. NHS organisations, have you started any recruitment yet for individuals who will undertake the review of assessments and or authorisation and or AMCPs? And once you've answered that question, don't close your Slido window, because we will just return to it for a final question at the end of the webinar. Okay. So thank you for that. As I say, don't close the Slido window just yet, but I hope you found those results interesting, but also quite reassuring that it's not that everyone else is really far ahead and has got this nailed already. So do take some comfort from that. As we gather information as part of our work, ideas, possible solutions, we'll be iteratively producing a baseline in our benchmarking report, which we'll share back with the participants. And alongside that, we'll be running the second prong of our work. Now, I don't know what central or regional practical support might be available and what that's going to look like. Some of you on the call today might actually have a much better idea. But we want to help fill in the gaps and try to prevent every organisation reinventing the multiple wheels that will be needed for this Goliath of a truck. So this might be a variety of things, such as training videos, understanding tests, databases, where you can't capture LPS on your existing electronic systems, template policies, audit tools, information leaflets, or it might be as simple as bringing together groups of organisations who all use the same electronic records system to leverage combined power over electronic system providers. As plans emerge and regional leads possibly get appointed, we'll obviously make ourselves known to them and offer support. And we've also been in discussions with Hill Dickinson about how they could contribute to and support this work, and would welcome any suggestions from yourselves about what it is that you might find most useful. So thank you for your time today, and please don't hesitate to get in contact if you want to get involved or find out more. But I'll now hand back to Ben for the Q&A session.
Thanks, Elaine. Just to give everyone a chance to put any questions, if they haven't already, into the chat box. Can we move on to the how are you feeling now Slido, and perhaps I'll keep an eye on the chat box while you do that, if you don't mind. I've been trying to answer questions in the chat box as we go. I'm conscious I've missed one. How are you feeling about LPS now? It would be useful to know, just to compare and contrast. Slightly better, that's what we're hoping for. Clearer, reassured, okay. Remain concerned. I think that's fair enough. I like that. Thank you. And coming from the chat box earlier, scared stiff, which was nice to see. As I said, we can't promise all the answers just now. Actually, I see we have been joined by someone who might know an answer to a question that I didn't. Hilary, if you can hear me, Hilary Paxton, who's got a role through ADAS.
Hello there.
And I think the local government organisation. Hello, thank you for joining us. There is a specific question I didn't know the answer to, and I don't know if you do. We've been asked: is the DST national form, the decision support tool, going to be amended to accommodate questions about LPS issues so that can be used? Is that something you know about?
I don't know the specific. You're talking about the continuing healthcare decision support tool, I think. Is that correct?
Yes.
So what I do know is that the National Strategic Improvement Programme for Continuing Healthcare has been involved with us, but I haven't asked that specific question of them.
Okay.
And what I would say is that whoever has responsibility for continuing healthcare obviously will need to be thinking about those questions. So what it might be helpful to do is to check that out with the National Continuing Healthcare lead officers to check that. I would think that people doing continuing healthcare assessments would need to be thinking about DOLS and LPS as part of their work. So I think it may not be on the same form, but it certainly needs to be part of the same process.
Yes.
So a very simple suggestion.
Thanks, Hilary, and that's very much the ethos of LPS, isn't it? To build the thinking about protection of Article 5 rights into the care planning and delivery, not to be a sort of after the event exercise, which makes sense. Louise Wilson, a colleague of mine, has very helpfully replied in the chat box a question I hadn't picked up about the question of application in prison. As she says, any deprivation of a person's liberty while they're in prison tends to be covered under the criminal law, which authorises their detention. So for Article 5 of the European Convention of Human Rights purposes, it's the criminal law and due process that deals with that. If there's a specific question about the application of DOLS or LPS alongside that in that context, I'd be pleased to hear it. We can have a think about it for you. If anyone missed it in the chat box, one thing that came up a couple of times was about the CCG role and what the position is where it's a 50-50 package funded between the CCG and the local authority. That falls to the local authority because the CCG's responsibility as responsible body comes from continuing healthcare funding of the package, and it is continuing healthcare funding of the package. The same responsibilities don't follow even if the CCG funds 100% of a Section 117 package, or if it was 95% of a joint package. It's not about the majority funding. It's about continuing healthcare responsibility, bringing with it the responsibilities for CCGs. Though of course they are shortly to leave us and be replaced by the ICS systems. Thank you, Jackie, who's put something about the DST into the chat box, and thank you, Hilary, for joining us. I will come back to the chat box in just a second. Oh no, it's always about CHC. A little confused about the CHC point. At the point of the DST, it's not known it's fully eligible. Yes, that's right. It will be when it is clear that there is a CHC package in place that the responsibility falls to the CCG. And you're right, we are going to be looking for some help on BIA AMCP conversion from Lorraine Curry and Neil Allen, which I'm very pleased to see. Lorraine, could I ask you just, sorry, Elaine, could I just ask you to move on a slide just to wrap things up for us? How we can help. I hope that this session has been helpful, and there will be more for us to talk about, and we'll be continuing the program of doing webinars. As we've set out on that slide there, we're very happy to provide more bespoke support for individual organisations to talk about how all this affects you specifically, both at board level and at the front line. Development and implementation of policies is something we're doing an awful lot of work on, and of course the very, very high levels of training that are needed across the system, both in person and remotely. The supporting documentation for the implementation, of course, is something we're also working on, and all the cases that will still be going to the Court of Protection under LPS, just like they're going through under DOLS and the current Court of Protection applications, is something that we do an awful lot of. I should probably add to that list taking the DOL in the community applications to the Court of Protection for CCG clients at the moment. Is something we are seeing more and more of. But for now, let me just flag the next session we will do is penciled in for the 7th of October 2021. I am delighted to say we'll be joined by two more external speakers for that one, and we have penciled in Tim Spencer-Lane of the Government Legal Department, who's responsible for leading on the legislation and leading on the regulations that will implement the liberty protection safeguards. And we're also due to be joined by Kenny Gibson, who is the National Head of Safeguarding for NHS England. So please do pencil in that session, and we will be in touch with invitations nearer the time. In the meantime, if there is anything we can do to help you, please do get in touch to any one of us individually, or using that general email address which we set up to help with the Liberty Protection Safeguards work, lps@hilldickinson.com. I will just have one more look through the questions.
I've got a question from Susan Forey, but she doesn't have access to the chat box. Susan, do you want to ask your question? I don't actually have the question. I just know that she has one.
Oh. No, she's got one. I don't know that we're able to unmute.
Unmute. Susan, perhaps send me the question and I'll ask it.
Okay. It might be that any more questions, let's say, send them through, please, and we'll get back to you after the session, if that's okay. Because we're just coming up to midday now. So thank you all very much indeed for joining the session. I hope it's helpful. We would welcome feedback, comments, suggestions on that same lps@hilldickinson.com website. It's really important to us that we spend time and effort and resources doing stuff that's actually useful for you, rather than what we think will be useful for you. So do tell us if this was helpful. Tell us if something else would be more helpful. Get in touch, and we look forward to hearing from you. Thank you very much for attending today, and we'll see you all soon. And thank you to Paul and to Elaine for speaking. Thank you very much. Bye-bye.